Hello, nice to meet all of you. Asked to come and do some kind of advanced troubleshooting so you understand how our pump monitors the helium and deals with it and gives you some more tools when you have alarms, because our alarms are going to be similar but different because we monitor helium differently than your previous pump on that. So we kind of go through that and show you some actual examples that were from here in the troubleshooting that we had. So first off, we have alarm system on our pump, never shuts down, doesn't shut off for any heart rate, doesn't shut off for any conditions. It's always monitoring the helium on a beat to beat basis. So we have several levels of alarm. Kind of the lowest level of alarm is kind of just a message alarm. It'll be a blue banner that comes up on the screen. The pump will still be pumping, but there's a message. Maybe a lead came off, maybe a low helium tank. So it's just a message alarm. Pump is still pumping, but it says there's something that you might need to check. Our medium alarm is going to be a yellow alarm. The pump is going to be beeping at you and giving you information about the alarm. And usually I see the yellow alarm come up when we are in standby too long. We pause the balloon pump to listen heart, lungs, check out the patient, and we're in standby too long. The high priority alarms are the red alarms, and the pump will stop pumping. It will give you an audible tone and it will give you troubleshooting, but the pump stops pumping. This would be similar to your older pump that you had with your kink line and gas loss. Those two alarms, the pump would stop pumping for those alarms, and you had to do your troubleshooting. We will provide you the troubleshooting on the screen. So again, a blue alarm is just a message alarm. The pump is still pumping. Low helium tank, they popped off a lead. It tells you what lead. And in the message bar, it actually tells you on those what the troubleshooting would be. So it's not something I have to go look up. It's right there on the screen. Some further yellow ones, the pump does stop pumping. It's beeping at you. This is usually because I've been in standby too long, or I have no signals on the pump for the pump to work with. I've got to have an ECG or arterial pressure on the screen for the pump to work. The red alarms, these are the helium alarms, and the pump does stop pumping again. Also, you can get a red alarm if there's a system error alarm. That's usually a computer issue. So if there's something wrong with the computer on the pump, then you might get a system error alarm and the pump does stop pumping for that. There will be a message on the screen, also in a text box, that tells you the troubleshooting for those alarms on that. So the different levels. The helium alarms are based off of what's happening to the balloon pressure waveform. You had this on your other pump. However, it was a non-calibrated, it was just a picture, so they could not use it to troubleshoot or quantify it, anything that's going on with the balloon. So the balloon pressure waveform, and I'm just going to flip up here and post this to add. We have a zero line. This is where the helium zero line on ours. So it comes up, fills the bellows. We've got the helium ready to go out to the balloon. Now the pump is going to push the helium out to the balloon. We go straight out. There is a transducer inside of the pump that monitors this helium going in and out. So as it goes past that transducer, we get the fleeing artifact, kind of like when we do a square wave test on an arterial line. Then it settles down and the balloon starts to get fully inflated. So it plateaus out. At the end of the seat, that's the end of diastole. So now the pump pulls the helium back to the bellows, goes past that transducer again, so we get the fleeing artifact, opposite of this, down below zero and back on zero. That's how this is created. That's why we see one of these every time the balloon goes to inflate. So width is always going to represent how long the balloon's inflated. So when they're tachycardic, it's pretty narrow, but it's always coming back to baseline before it inflates. Bradycardic, of course, much wider. And then when you have an irregular rhythm, it's going to vary beat to beat because you've got different diastolic times. So when you got a real tachycardic patient, you're not going to see a plateau because your diastolic time is so short. But the pump is monitoring the helium at the baseline. This is one of your patients. and the pump is pumping and handle that. Our pump can handle heart rates of 200 on that. As long as I can get back to baseline and get ready and get in and out, we can monitor, we can pump for every one of those beats and support the patient. But it's going to have to get back to baseline because I've got my healing ready for the next beat. That's where it monitors that. Now, again, this is how it's created. We are a vacuum, we're not a vacuum compressor system. We are a motor driver bellows. So the bellows opens up to fill for the size of the balloon. So if I got a 40 cc balloon, it opens up for 40. All of the dead space in our pump, tubing, dead space in the pump is the same, no matter what size balloon you put in. So when we plug in our balloon catheter, because it has a connection that tells the pump the size of the balloon, bellows opens up for that size. Then when it's ready to inflate, so we're up on 0, got my healing ready, bellows pushes that volume to the balloon, goes straight out, goes past the transducer, plateaus out, and then the bellows pulls it back out when we're ready to deflate. So this is why we're different from a vacuum compressor. We are a motor driver bellows system. This is a stainless steel bellows. This never wears out. This is pretty much the same design they've used since the beginning, back in the 60s, 70s, when we started all of this on it. Now, the other thing we can tell is what's happening inside of the aortic against that balloon, because this is calibrated. So if I've got somebody who's vasoconstricted or hypertensive, the pump's going to have to use more pressure to push that volume to the balloon. So the seat elevates because it says, I'm going to get it all in there, but I've got something pushing against me. So I'm going to have to raise that pressure. And if he's vasodilated, hypotensive, it doesn't take very much pressure to push that 40 in, the seat will be lower. Because we know the pressure that the pump is using to deliver that volume, we can compare what's going on with the aorta. When the balloon is inflated, your augmentation pressure on the arterial line is the pressure against the balloon at the time the balloon is inflated. And we can measure this pressure because this is calibrated. We can compare, there's a constant relationship between the plateau and the augmentation. The plateau pressure should be within 20 to 25 millimeters, plus or minus whatever my augmentation is. So this plateau pressure could be 25 millimeters higher to 25 millimeters lower. What that tells me, if I've got it in that range, is one, the balloon's in good position, probably hitting the second to third intercostal space on my anterior chest x-ray, and we're getting about 85 to 90% occlusion. How we use that. If I've got somebody who's very vasoconstricted, we're hitting a lot of pressors, or we put the wrong size balloon in, he's 5, I had this one the other night, 5'4", and they put a 50 cc balloon in that patient. It's too big for that aorta. So the plateau pressure was much higher than the augmentation because it's too big. Because we know this relationship, and because we're a volume-driven pump, I can decrease the volume in the balloon so that these two pressures are within range of each other. We can precisely do that. So again, somebody who's getting hit with hardwood pressors, we're going to need those pressors, but now the aorta is very constricted. The pump's trying to put it in. I might be getting a high pressure alarm, or this is much higher. This is much higher than my augmentation. I don't want to be pounding on the wall or against plaque, putting a hole in the balloon. So we can decrease the volume in the balloon, get our 85 to 90% occlusion, and be safe in that. We take the pressors off, then we can add our volume back. So we have that ability to adjust based on what we see inside of that. This is how we would look at that calibration for that sizing. Here I've got a plateau pressure of 172, but his augmentation is only 127. So this is using more pressure. The balloon's too big for this aorta. Now I have to look at a couple of things. Is it because I put in the wrong size balloon? Is it because I've got this patient a lot of pressors, or is the balloon not in the right position? If the balloon's too low, it's too tight. So maybe I need to get it repositioned. So those are usually the causes that we look at. So here we decrease the volume from 40. We went to 37.5 because I can decrease by 0.5 increments. And now the plateau pressure is 122, the augmentation that you look at right now. This patient was probably due to volume or pressures on this patient. He had the right side of the balloon in. It was just the fact that he had too many pressures on him. So this is where we would adjust our volume on our pump on that. And this is how we look at that calculation on that. Now I don't have to do that on every patient, but it's certainly helpful when I know I'm putting a lot of pressures on the patient. He's cold, he's clamped down. Maybe we were a little bit concerned about the size of the balloon for this position or for this patient, or if the patient's been restless, gets a hold of the catheter, corrects the sutures, pulls it down. The pump's still pumping, but this could be too high, and I could be getting those alarms. On this one, a couple of things you can see. Yeah.
Sorry. Is there any automation to the machine augmenting the volume that it's filling the balloon, or is that only manual and something that
I can't increase because what you're used to on the other pump, that's a pressure pump. And so the augmentation that you're adjusting is not volume, that is pressure on that. That pump will deliver 60 to 70 cc's every time the balloon goes to inflate, regardless of the size balloon you put in. It's going to deliver. Well, wait a minute, I just put in a 30 cc balloon. I don't need 60 or 70 in that. So how they manage it on that is they add tubing length. So if I'm delivering 60 to 70 over that distance, I'm getting less in the balloon, but you have no idea how much volume wise. So they always told us running that balloon pump, you get the balloon in, you run the augmentation knob clear to the top. What's that doing? That's delivering that 60 to 70 as fast and as hard as it can to get that balloon open. Once it's open, then they say, come down. Now, this is what I always found it was interesting, but don't go past, there's my hash marks on that. Don't go past the halfway mark. I thought, well, why not? You got hash marks below. I used to have one of those nurses. What happens if I go below? What happens is you're not driving that 60 to 70 as fast. I'm getting less volume, but I have no idea. The problem is you might not be getting enough balloon inflation and could have folds on the balloon. So that's control of augmentation. On our, because we're a volume driven pump, the pump's never going to use any more pressure than it needs to get the balloon inflated. Your augmentation, when you look at augmentation, it's related to three things. First, how much volume is in the aorta to displace? So if I've got somebody who's hypovolemic, he's not giving me very much stroke volume to work with on an EF of 10. When the balloon inflates, it's displacing the volume, but there's not a lot there. My augmentation is not going to be up here like we think. We like that pretty picture. It's going to be down here. It might be down here because I don't have enough volume. He's hypovolemic. He's got a low stroke volume. Maybe I put in a balloon that's way too small for him. The other thing that augmentation is related to is how much the balloon is occluding the aorta. So if I'm not occluding the aorta as much, volume is going past the balloon rather than being displaced, augmentation is lower. Put the wrong side balloon in. And then position. The other thing is position. If the balloon is too low, then it's got too much distance. So that's how you get your augmentation. So when I have low augmentation on a patient and the pump's meeting all my criteria, then it's a patient-related issue that I have to look at, or position of the balloon, or is he vasodilated? Do I need to give him pressors? Do I need to reposition on that? So there's a difference between that. Yeah.
But to his question, it's set and then it's a manual.
Yeah,
adjustment.
because I can come down on the volume, but I can't go up. I can't make a balloon bigger than it is. Oh.
I was thinking more about with this total volume and describing that you can manually.
Yeah, I can
volume.
decrease because our connector on the catheters.
Automated by a machine.
Yeah. This connector that you see on our balloon catheters is specific for the size of balloon that you put in. So a white one is 30, a blue one is 40, and an orange one is 50. So this tubing comes in the balloon kit. So when I pull that balloon, when I plug it in, the balloon pump knows I just put in a 40 cc balloon. I can bring the volume down, but I can't make it bigger.
Can I ask a question about the balloon trays? So your idealized schematic, it's square wave up, overshoot, square wave down. Here, and we saw this on the prior machine a lot, the curve linear, which was a trouble sign. So what, can you explain the curve?
Why I don't see the plateau and the overshoot like that on this one?
Yeah, and the rebound from the undershoot, instead of square wave, gradually goes.
Yeah, that's because the scale only goes to -50.
You
If this would go down to like -150, you would see the overshoot pretty much the same down below, but because the scale stops at -50, it chops off the rest of it.
Why is this one different from other typical?
Oh, no, this one, okay, so, why, I have this one.
Yeah.
On that. Two things are happening on this patient. First off, I can tell that there's a kink going on to the catheter somewhere along the catheter, either in the patient, at the groin site, or external. There's something that's causing the helium to slow getting in and back out, okay? This is why the overshoot is wide. This is also time, right? Time. So it's taking a long time to get in. This is where the change, I can kind of see it right there, where that's where the plateau is. So it's taking a long time to get in past whatever obstruction. There's a little tiny plateau because this heart rate's only 80. That's not very, shouldn't be narrow, so much narrow because of rate. This is because of a kink slowing my helium getting in and out. Now it's ready to deflate. This is pretty wide down there before it gets back because it's having trouble getting past that obstruction back to baseline. The other thing the pump does to help manage this when you've got an obstruction somewhere on the catheter is it also pulls the deflation early. It says, I'm trying to get past that obstruction. So I'm going to pull the deflation in earlier, so maybe I can get past the obstruction and back to baseline. Because if it doesn't get back to baseline, I'm going to start getting alarms. So that's why it's narrow, because he's pulled the deflation in early, trying to compensate for the obstruction. And that's why these are so wide.
So is that a yellow alarm or a blue banner? So that's kinked line. What's the alarm you get on?
Right now, I'm not getting an alarm. This is getting back to baseline. It's not kinked enough that I'm getting a high pressure alarm or a helium loss. High pressure alarm means it's squaring out at 250. Still coming back to baseline. I'll show you those in a second. Helium loss is if it can't get back to baseline between the beats. Right now, the pump is pumping, but if his heart rate got faster, the problem will be, I may not have enough time to get back to baseline. I will get a possible helium loss alarm because I got to get back to baseline before I start my next inflation. And if I can't, then I need you to figure out why can't I get back to baseline. Typically, the most common place for the kink is not external. If it's got the tubing straight, it's not kinked. The most common place is right at the groin site. So either steep angle of insertion, tortuous anatomy, which they all had normal anatomy, but they don't. So anything that's causing my helium to slow in and out. Angle of insertion is very important for us to remember. The straighter you keep the catheter, the easier to get the helium in and out on that. And we all know when we have large patients, we want to do this because we're trying to get through all that tissue. But think about it, that catheter goes down, hits the femoral artery, and has to make a curve up into the aorta. Here's where your kink is. All the guy has to do is wiggle a little bit, and I've got more obstruction right there. Tricks that we do in staff-wise, because I can't reposition the catheter myself. I try to hyperextend the hip. That straightens my angle. Sometimes a little traction on the catheter straightens the angle. Sometimes just repositioning the patient helps us. Sometimes I can't. And then I'm calling you guys and saying, look, we either need to, I will try and decrease the volume first. I go, less volume past this, maybe I can keep it pumping. Otherwise, I'm going to be calling you, like, we either need to check to see repositioning this thing. Worst case scenario, if I got a severe kink, we may have to take the catheter out and try the other side. I had a patient that we typically use the right femoral artery, and it was awful. Had alarms, took it out, put it in the other side, it was fine. So this patient had worse porosity angle on the one side over the other. So that's how we go through troubleshooting, making sure we can try to get back.
So you're not going to get an alarm, but your peak balloon pressure is going to be well above the diastolic augment.
Now, there's where it is. It's reading 141. Or do we read that one? 104, and this is 110. When I can see a peak of the plateau right there, it's not this, it's right there.
Yeah.
And it's still within range. So the balloon's not too tight this way. This is all occurring because I've got some sort of kink to the catheter.
So you would disregard them.
Yes.
Okay.
Yeah, I don't need to change the volume at this point. I may have to change the volume if all my troubleshooting doesn't make this look more normal. And I get a faster heart rate, I may not be able to get back to baseline and I start getting phospholipid. So I might try decreasing the volume, see if I can get it past the obstruction faster and avoid the alarms. And sometimes when you do that, because he's got a 50 cc balloon, what you will see is if I can get it past the kink, this starts to look more narrow and I start to see more of a plateau, and I can identify that easier. Yeah. Okay, so this was 146. So here, my obstruction maybe have been related to, it's got a 50 cc balloon in here. So the first thing I would do on this one is decrease my volume, because my augmentation is only 110. That balloon's a little bit big. If I take it out, it's going to get past the tightness, and now I can see my plateau better. I put that. And again, that early deflation is because he says, I'm too tight. I'm going to pull it in and see if I can get past the obstruction or in and out easy. It's some sense.
I wouldn't phrase it as you're making it seem like by decreasing the volume, you're increasing the speed of the transit of the gas, and that's not actually true. By decreasing the volume,
It's easier to move it in and out based on his heart rate, past the obstruction.
and
If I have less volume to pass,
not the flow rate is independent. Your pressures will be lower because you're trying to push less volume, but it's not changing the speed. You're just reducing the volume. You're not
It's
actually
just the
changing the speed.
duration of the
Right. Yeah, exactly.
But for this, until it alarms versus how do we know
Yeah.
it's optimally ballooning?
yes.
In the beginning, I was completely obsessed with the chair. They told us to look for the chair. I was looking for the chair. And I called them for every lack of chair. And then they were like, we have to come do some other
Here,
troubleshooting.
that's 140 and my augmentation is 120, 110. The balloon is tight. So that means it's putting in all the volume, but that also means it's hitting the wall. So it means that balloon could be up against plaque, putting it at a higher risk for putting a hole in the balloon. And so that's the other reason we would decrease the volume, because I don't need the hole in this balloon and now we got to take it out and put a new balloon catheter in. So I'm looking at what it's doing inside of the aorta, that balloon against the wall.
So sequentially, I see this, I elevate my hip, I make sure my x-ray shows my, that's what we do with all the beginning cases, right? We check the x-ray, we up the hip, and then we decrease by, what did you say, increments of?
Because
2.5,
my,
3 cc?
yeah, I usually, when I start decreasing the volume, I usually start with 2 or 3 cc's. Then I remeasure, see where we're at. Because sometimes I don't need to take a lot out. I just need to take enough out so we're not too tight in the aorta.
And once I do that, I'm looking at my waveform and my numbers.
Yeah, you're then looking at this number compared to that number again. This is unique to our pump because we're volume driven and we know precisely what's going on with the volume with each bead. Rather than just delivering 60 to 70 cc's in minutes and trying to adjust that with tubing length. That's how the other pump works. Okay, need to be. So we're always getting back. Transition tortuous anatomy. Partial kink to the catheter anywhere along the line. It could be inside the patient because of twists and turns. It could be at the groin site. I had one time that the balloon was not advanced all the way through the sheath. So the end of the balloon was still inside the sheath, giving me messages. Sutures around the catheter kinks the catheter, making it harder to get the helium in and out. We use the flanges. We usually don't add extra sutures. And then the other thing that we have to watch out is condensation in the tubing. Our pump drains the condensation out, puts it in a little bottle so it doesn't get in the line. But if you ever saw condensation in the tubing, that will slow the ability for helium to get in and out. So I would watch for condensation. Our pump should not have condensation in the tubing. If it does, the staff didn't check the condensation bottle and empty it, or I've got an issue with that pump in removing the condensation. And then I would switch out that pump because our pump is supposed to try to keep that area dry. Get moisture.
If you think we see moisture in the tubing and we open the little door and there's only half a jar full of water, we should be.
So when it, yeah, I would empty it. Then the other thing to if the tubing is dangling down below the insertion, get the tubing up so it's easier for the pump to evacuate that tubing. I had a staff person call me one time and they got water like sloshing back and forth with the balloon inflating. And once we elevated up, the pump cleared it out. Right. So you don't want it dangling down because that makes it harder for the pump to get rid of that condensation. Condensation is normal because we've got old helium going into our body, creates condensation. Again, here's the straighter it is, the easier to get in and out. So here, back to zero. As we start adding the kink, this gets harder to get it in and harder to get back out. Keep increasing it wider, wider. I can barely see my plateau here because we've got so much structure. I almost felt, see how it's having a hard time getting back to baseline because the more kink you have to the catheter, more difficulty I'm going to have. Now, it's getting in and out. I'm not getting an alarm yet. His heart rate gets faster. He won't be able to get back to baseline. I won't see this. It'll square out at 250. I'll either get high pressure alarm or possible helium alarm. Like he says, if it's not getting back, did I lose helium? If it's squaring out at 250, I've got a high pressure alarm. He said I should not have to use 250 millimeters to get the helium in that blood. Did not have to use that. And pressure to push that in.
There an angle for, I don't insert balloons, but these people do. When they do, is there something that's going to trigger for them? Like I need to be below this angle.
Yeah, if you look at any catheter, I don't care whose catheter, says we should not be more than 45-degree angle of insertion. That's difficult in a lot of our patients because in my experience, our patients haven't gotten smaller over the years. So we start doing this and this. And again, that makes it more difficult. Sometimes in the cath lab, what I will do is, if I know we've got a large patient, before they even make this, I will put something under the hip and hyperextend it so I have a straighter angle.
They just have to maintain that throughout care.
Yeah, because the minute you take it out,
Hmm.
I got more kink to the catheter. Again, straighter. Here I've got this little lady had 2 S curves in her aorta. The pump is pumping at this point. But I knew if her heart rate got faster, I'd start getting the alarms because now I've got to get it in and out past all of these obstructions. I can actually shift this patient. She's got a severe
How are you?
kink to that catheter up that close.
Yeah. Yeah.
Right time.
Okay, cool.
Yeah.
Thank you, sir.
As long as I can keep her heart rate low, I can get that helium in and out. Faster the heart rate gets, I'm not gonna get it in and out, I'm gonna get alarms. Decreasing the volume here might help, getting past that if her heart rate gets faster. But that's what we're up against if I have a lot of tortuosity in that catheter or in the body. Okay, if you look at this one, couple of things you see right off. If I look at this, I am not getting back to zero between those. Now, if you look up here, I have no augmentation because the helium can't get past what other obstruction is there to get to the balloon, to get it inflated, to give me my augmentation. I need to figure out where this kink is pretty quick. Because I'm not getting any inflation to that balloon to give you any augmentation pressure. So I start doing all the troubleshooting. Angle of insertion, repositioning the patient, decreasing the volume, checking my x-ray. High plateau pressure, because he's having a hard time getting it in and out, using a lot of pressure to deliver, trying to get that helium in the balloon, but I see no augmentation. It's not getting to the balloon. Then what we did to this one, but I thought I've got to get something to the balloon so we can troubleshoot this. We went to 1 to 2. Now I've got more time to allow the helium to get past whatever obstruction is. It gets back to baseline. This starts to look a little more normal. I've got some augmentation in, but I have late deflation. That's because it's taking so much time to get back out that I have late deflation. So now I need to try and decrease my volume. We may have to replace this balloon. But that's the difference that you can see with that. We call that a slow balloon, trying to get the helium in and out. Condensation in the tubing, again, can affect my helium getting in and out. So again, we do check this between, and I live in Colorado. We have a really dry humidity. We don't have a lot of humidity. So I'm not going to have a lot of extra condensation in my bottle. But you guys have humidity at times here. You may get more condensation than I'm used to. I worked in Pittsburgh one summer. We got 30 cc's of condensation in the bottle every shift. So we got used to checking and emptying that, because if I have condensation, that's going to slow my helium getting in and out and affect my augmentation and my timing and my alarms. So that's looking at that. Now, we have 2 levels of possible helium loss alarms. It'll say possible helium loss, there'll be a 2 behind it, or possible helium loss 3. It's looking at this waveform and looking at the baseline. If it drops down below 0 and doesn't get back, I'm going to get a possible helium loss alarm. 2 levels. I mean, these are the basic things that we look at. Do I have my worst case scenario? Anytime I see a possible helium loss, doesn't matter which number's behind that. The first thing I look at, is there any sort of signs of blood in the tubing? We all know that these guys have plaque and cholesterol in their aorta, calcified, could be specks, and a lot of times it's specks. This is not going to be tubing filling full of blood or streaks. It's usually flex in the tubing. Catheter has to come out. The biggest problem we don't know when you have blood in the tubing is how much blood is inside that balloon on that. And we know if I leave it in, you know, let's say it's still pumping, and I leave it in, the problem is we know helium going past a clot inside of a balloon crystallizes that clot. And so now when you try to remove it, it's stuck. And that's an entrapped balloon, and you all now have to take that person to the OR and get that balloon out. So that's why the staff is very concerned about watching the tubing. And if the blood gets all the way through the pump, you're gonna see it inside the condensation valve. That's a bad sign, because that means blood got all the way through the pump. It has to go to biomed. They can't clean that. It's parts that have to be replaced in the thousands of dollars worth of parts. So that's why staff are very concerned if they see this. We don't want blood inside the pump. The other places that you can have a possible healing loss could be the connector itself. This is rare, but if I have splits on my little O-rings, there's your healing loss. I'm gonna have to change out this connector on that. And then making sure that my connection is tight here. Now, if you receive a patient from another institution who has a McKay balloon in, they have that male connector on it. You're going to have to use adapters to plug into my pump. I often find the adapter is where the leak is at on that, because it's a leak point. The male connector goes in the back of that, and there's a leak point. So my trick on that one, I did transport, so we go anywhere. Pick up balloons. When you put the male connector into the adapter, you push it in and you twist. That will tighten. If it continues to leak at that, I have to change out the adapter on that. So these are two other places that can be leaks. It's not getting back to zero, just below zero. And I start getting the healing loss 2. This is usually a healing loss 2. I'll have a banner of the healing loss 2. Here's the same idea. We're on 0, and then it just barely drops down below 0. The pump can detect less than a half a cc loss of helium. That's why we're so precise in looking at this. Possible helium loss 2 is the one that I think of a lot of times. There's possible little hole in the balloon or a connection site. Possibly in loss 3 on baseline here drops down below baseline. Then squares off. This is usually, I like to see this one because this is usually a kink. And I need to find my kink, repositioning the patient, straightening tubing. Those are the kinds of things. Possibly in loss 3, I'm almost glad to see because I know it's a kink. Let me see what I can do to relieve the kink. 2 is usually a hole in the balloon. So here's 1. Down below 0. Oh, we went to 1 to 2. It finally got back. So I know I'm dealing with a kink here because I can't get back because of the kink. Look at that. High plateau. His augmentation is only 61. Low augmentation because it's not getting very much volume to the balloon to inflate it. But when I went 1 to 2, at least I could see more augmentation. Not really here, because I can get the healing in and out a little better. Now I have to go after relieving the kink. I'm trying to figure out where's the kink in. And I end up having to try and drop the volume to get past the kink.
So when you have a helium loss, why don't you get back to the baseline?
Because the pump says I have to have all that volume back ready for the next speed. If I don't have it all back, something's wrong. Something's wrong. If I can't get that helium back to baseline before the next beat, what's wrong? What's preventing me from getting that helium back and forth? Usually a kink.
Not the kink. If you have a minor helium leak, microperforation.
Ah, because the pump can detect less than a half a cc. So a micro puncture. I might not even see blood in the tubing yet. The pump sent 40 out, expecting 40 back. Didn't get 40 back because it lost a little bit.
Continue to pull.
Yeah, because it says I'll refill once. I'll refill. The monitoring does micro refills to always make sure you have the volume. So it says I sent it out. I got it. I didn't get all of it back. I'll refill. And then it sends it out again and it says, "Ooh, I didn't get it back." Now he's going to give you a 1, possibly lane loss 2. And people think, why is this alarming? I don't see any blood in the tubing. He's not tachycardic. He's paralyzed. He's not moving. Why is he getting this alarm? Because pump can see a problem. And that one, it would be pulse feeling loss 2 is like this one. It's not getting back to 0. It's just barely below. And so he's refilled once, the pump will refill once. And then if it says, I see it again, I shouldn't have to refill like that every minute. And so the alarm's pulse feeling loss 2, when I think of it being a hole in the balloon, it's coming like every 2 to 3 minutes. People will restart the pump. And then in 2 minutes, I get the alarm again. Don't see any blood. Restart again.
See, what I don't understand is if it's a bellows and it's volume.
Yeah, but it's
So when
monitoring
you detect that you're not getting the volume
back to the bellows.
So it just.
But
Mhm.
you're monitoring pressure there, but it's measuring volume.
Because the bellows is
Yeah.
volume.
And I don't know how it adjusts for temperature, but somehow it adjusts for temperature. It's all separate.
The magic of engineering, which I'm a nurse. So I would need to talk to those guys to understand it better. I just know that the pump, it's like pushing it in, pulling it out. And I'm expecting 40 to come back, and it didn't get 40 back.
These are red or yellow and not functioning pump at that point.
What's that?
That's red or yellow.
Red.
And so it's not working.
It'll stop pumping. It says, there's something that you need to troubleshoot now. The pump is a machine. He says, I see a problem. I don't know. Is it a hole? Is it a connection site? Pump doesn't know that part. Not that smart. But I'm going to have to troubleshoot. Why do I keep getting it? So the pump says, I didn't get 40 back to that bellows. All micro refill from the tank to get 40 to go out for the next piece. If I don't get it back, this is something more than a pump issue. This is not a pump issue. This is a patient side issue. And I got to figure out why that is. So pulse failing loss too, a lot of times you won't see blood in the tube. But the pump keeps alarming every 2 to 3 minutes. I hate that. Connection site or hole in the balloon. We can actually do an internal leak test with the balloon in the patient. Next. So this is before we get to that one. Again, pulse feeling loss on 0, on 0, on 0 doesn't. This is going to be a pulse feeling loss 3 alarm because this is so far below 0. Now this occurred only for these 2 beats and it got back. And that's because of this irregular rhythm and it triggered early. This is an occasional one. I see it happening. I just let the pump go. But if it's frequent and this is staying down below 0, not getting back, I got to figure out where my kink is. Again, another severe kink, no augmentation. Did I go backwards? I did go, sorry, went backwards. Okay, so here's my possible healing loss 3. Definitely down below 0. This is usually a kink. I like this one because it's a kink. It's not a hole in the balloon. There's my troubleshooting.
I wish you would rename that. That's what throws people, calling it a possible healing loss.
But it is to the pump, it's a possible healing loss because he said I didn't get it
But
back.
it's not though, really.
Well, to him it is. To the pump it is because he's saying I got to have it back. I didn't get it
Yeah,
back.
but
So
you know-
why is my loss?
You know it's, well, we talked about this before, but that's what throws people, the fact that you're calling it a healing loss. People are thinking the balloon ruptured.
They're
It's
thinking
not.
the whole balloon first.
It's
because
not.
you're used to the only choices you had on your other one, kink line or gas loss.
Call it a helium deficit.
Whatever you want, whatever, something else, but anyway, that's a separate issue.
Now you gotta take that up because company's been around for 50, 60 years and have always called it possible healing loss on our books. On that. Arrhythmia detected, so I'm getting back to the baseline here. Short interval. Pump says there's a little bit of obstruction because of the irregular rhythm. It pulled the deflation in early to try and get it past where their obstruction is. Now, the other thing that you can see of the pump sometimes, you'll get the message possible late deflation because it's got an irregular rhythm, got a very short cycle here. There's my late deflation. He says, is that bad for that patient? Well, that was an occasional leak. Short cycle, I expect. It was frequent and I'm getting late deflation alarms. Then I may have to look at, do I need to do some adjustment to my timing? I may have to go to operator mode and change it. Because late deflation can be bad for patients, not always. Not always. So I can assess that. I want to get to the yeah. Heart rate's only 76, but this is kind of narrow. He's pulled the deflation early to try to get past whatever obstruction is, so he can get this helium back between each one. Repositioning the patient, straightening out the patient, hyperextending the hip. This is my healing loss too, just basically below. That's where I'm more likely going to see a possible healing loss. 2 is a hole in the balloon. You might not see one. We do an internal leak test on this pump because it can monitor the healing base beat to beat. So to do this test, we turn off the alarm, because I'm going to make an alarm when I do this. I get a pair of hemostats. And I clamp on the tubing as close as I can to the patient. I clamp it there. So now I've isolated the balloon and I'm monitoring anything from the pump up to this point. I turn the pump on and I watch this. Now I'm going to get a high pressure line because this is squaring off at 250. That's because I clamped. Perfect. I know that. But what I'm watching is this. Because that's where I'm looking for this possible helium loss. If I'm clamped here, and this stays absolutely on 0, I just found my hole in the balloon. Because I am only doing this test because I'm getting a possible healing loss 2 alarm every 2 to 3 minutes. So I've isolated the balloon. I no longer have a drop in my baseline. The problem is my balloon catheter. Well, you guys got to take the catheter out. I found the hole. There's just no blood in the tube. Now, if I clamp there and I'm watching this and it drops down, it is not the balloon. It's somewhere from that clamp towards the pump. So I take my clamp off, the pump off, clamp it down at the connection down here to the pump. I do the test again. If it drops down below 0, good. It's either connector or the pump. I mean, it could be a pump issue. I can change out the connector or I can change out the pump. If it doesn't drop down below 0, great. It's somewhere between this clamp and this one. I will check usually the connection on both sides of that is rare, but I've had that. They have a fracture in it and there was my kink. There was my healing loss. So I ended up having to cut this out, use a 5-in-1 connector, put it in there. They had duct tape, non-porous tape to prevent that leak at that point. That's an internal leak test with the balloon in the patient. It's very helpful. I usually think about doing this. We're getting the possible healing loss 2 alarms every 2 to 3 minutes. I don't see blood in the tubing, but the pump sees a problem. It sees a hole. It's not getting the healing back.
Can you differentiate that from a kink? Because that's the
I'm
same.
sorry.
How can you differentiate that from a kink, right? It's the same.
A kink, if it was a kink, I would have been getting back to baseline and it wouldn't be possibly healing loss 2. It'd probably be possibly healing loss 3. It's all based on the way that balloon pressure waveform looks and how it's getting back to the baseline. Possibly healing loss 3, the baseline drops much more significantly. It's definitely a drop. And that's a kink. Can't get past it back to the pump. Possibly healing loss 2 is if I'm getting most of it back, I'm just not getting all of it back. But I don't see blood in the tube. There's a difference in the drop.
The only helium leak test for repeated helium loss 2s.
Yeah, I only do the internal leak test when it's a possible helium loss 2. And those alarms keep coming. This is what staff will do. They'll get it. They don't see a problem. They start with stupid balloon pump. They started again, and 2 minutes later, they get the alarm again. They're like, what's wrong with this stupid balloon pump? They started again, and they have 2 more minutes. They get the alarm. The pump doesn't alarm unless there's a reason to alarm. It says, I see a problem. You don't see blood. I see the problem. And so that's when I do that's when I do the internal leak test. Yeah. It's the positive and loss too that we hate as clinicians because that's usually a hole. Usually all. Could be a connection site with the adapter. That could be the issue. Those adapters don't come from us. Those come from the K. So that's been a problem. I usually keep extra of those because that could be the problem. I need to change everything adapter.
Quick heads up, we have this conference following here at 8:30.
Okay.
Julie, do you
No,
want to just make
timing is
comments
perfect.
about when they insert it and this zero,
that?
not touching when you zero? Do you want to speak to that? They're inserters.
I'm sorry, what?
We've had issues when it doesn't get zeroed appropriately.
Oh, the fiber optic zeroing?
So just
Okay.
speak to that to them.
This is high pressure, by the way, because I've got the Helium, but I'm using 250. This is usually a kink, can't get past the kink. It's using 2-inch pressures. So I'm looking for a kink on that. Your fiber optic connection. The sensors on the tip of the balloon. The only time you can zero fiber optic is before I put it in the body. Otherwise, there's going to be pressure on that sensor. I can calibrate a fiber optic once it's in. So I calibrate in an SVO2 swatter every shift. But I can't zero it because there's no way to open that sensor back to zero, back to air if it's in the body. So in the insertion process, when the first thing I want the scrub people to do when they're helping you all with that is hand out the fiber optic connection to the circulator. They will connect to the pump. The pump will automatically zero. It takes 10 to 15 seconds. The key that they have to remember is don't touch the catheter while it's zeroing. When it's in the package, it's open to air. But if I try to flush it, I try to manipulate it, I try to take it out of the package, I will get a false zero. You may not have accurate pressure readings, or you may not even see a waveform because it's way off the scale because it didn't get zero on that. So I usually have them hand off that connection first. Then what we're doing is getting access, even if all we're doing is exchanging out a sheath for the balloon sheath. That's going to give me my 10 seconds. Once it is zeroed, then we prep the balloon, take it out, take the stylet out, flush it, take the hemostasis device off, put it in. If you have a crash and burn and you don't have time for that 10 seconds, put the catheter in. After you get the catheter in, hand off the yellow cord. They can hook it to the balloon pump. I should see a waveform. I can't trust the pressure readings because it wasn't zero. I can calibrate it later. If you're worried about your pressure readings, you can always look at the central lumen where you put the guide wire up. We're going to hook a transducer to that. We're going to keep it paint. Because if I have to change out the balloon, I've got access there. If my fiber breaks, because it's a glass wire, pump will automatically use that arterial line for timing. With that central lumen, I can zero that one because the transducer is the outside the body. So then I can take the pressure reading from my transducer and calibrate my fiber optic so that I have accurate pressure readings from the fiber optic. I prefer, give me that 10 seconds. You can give me that 10 seconds to get it zeroed. Okay. Fiber will work great for you.
Julie, thank you very much.
Thank you.
Excellent.
Great job.